This module will provide an overview of shock. Upon completion of this module, you should be able to define shock, hypoperfusion, discuss components for normal perfusion, list the causes of shock, list the three stages or categories of shock, and differentiate between signs and symptoms of the three stages, identify the compensatory mechanisms related to shock, list various types of shock, differentiate between causes, signs, and symptoms of the various types of shock, explain appropriate care for patients exhibiting signs and symptoms associated with each type of shock, discuss general assessment components of adult and pediatric patients, analyze the need for expedient care and transport of shock patients, and describe age-related variations when assessing and treating a pediatric or a geriatric patient in shock. You should also be able to complete the following affective and psychomotor objectives upon completion of this lesson. Explain the sense of urgency to transport patients that are bleeding and show signs of shock. Explain the rationale for having knowledge and skills appropriate for dealing with pediatric and geriatric patients in shock. Problem solve how to appropriately provide emergency care for a patient exhibiting signs and symptoms of shock. For the purposes of discussing shock, it is important to understand the concept of tissue perfusion. Within this context, perfusion is defined as the adequate delivery and removal of gases, minerals, and other nutrients to body tissues and the cells from which they are comprised. Of significant importance is the adequate delivery of oxygen to the cells. Take a moment and think back to the anatomy and physiology module in which the circulatory system was discussed. Our circulatory system is a closed-loop hydraulic system. For that system to work properly, we need a functioning pump, the heart, adequate fluid, our blood, and the system itself, the blood vessels, must be responsive to change. If any one of these elements experiences a deficiency or failure, adequate perfusion becomes challenging at best, impossible at worst. Delving a little deeper into these elements, we'll begin with the system's pump, the heart. It is the responsibility of the heart to move our blood around within the body. Blood moves from the right atrium into the right ventricle before proceeding into the lungs. Within the lungs, carbon dioxide in the blood is exchanged through the alveolar wall with oxygen from the air. From the lungs, freshly oxygenated blood proceeds into the left atrium before proceeding into the left ventricle, where it is then pumped out to the rest of the body. Once the oxygen from the blood is delivered to the cells that make up our various tissues and organs, and the waste products from cellular metabolism, carbon dioxide in particular, are absorbed into the blood makes its journey back to the right atrium. If the heart is not functioning properly, perfusion problems will occur. Depending on the nature of the cardiac dysfunction, those perfusion problems may be subtle or they may be catastrophic. Even if the heart is pumping effectively, adequate perfusion also depends on the blood itself and the components within the blood, such as our red blood cells. If a patient suffers severe trauma, for instance, and has profuse, uncontrolled bleeding, a good, strong heartbeat loses effectiveness if there is no longer any blood to circulate around the body. With that being said, the relative nature of the circulatory system itself is also a consideration for perfusion. Blood vessels within the body, namely arteries and veins, have the ability to constrict and dilate. If all these vessels within the body dilate at once, that increases the size of the proverbial container. Unless the amount of fluid, blood, is increased to correlate with the increase in the size of the circulatory system container, relative hypovolemia, low blood volume, will result, which will also impact perfusion. Even if the blood vessels are able to constrict themselves to conserve blood, having a leak within the system can also negatively impact perfusion depending on the size and location of the leak. These three components, pump, fluid, and container, heart, blood, and vessels, are part of the overall circulatory system, and a problem with just one of these three components can have a profound impact on the body's ability to adequately perfuse its cells, tissues, and organs. Now that you are familiar with perfusion, shock is easy to define. Shock, otherwise called hypoperfusion, is simply the inability to adequately perfuse the body's cells. Stated another way, shock occurs when the body can no longer provide oxygen and other nutrients to and remove metabolic waste products from the cells. Shock can lead to death if not corrected and reversed. How quickly that process occurs depends on the nature of the underlying pathology. With that being said, early recognition and treatment of shock is vital to the patient's chances for survival. To have good perfusion, we need a working pump, adequate fluid, and a healthy container. If one of those elements fails or is disrupted in its proper functioning, perfusion will be impacted, resulting in the development of hypoperfusion, shock. Taking each element in turn, we'll begin with a look at our pump. The heart can fail as a result of numerous pathologies. Blunt trauma to the chest can disrupt the heart's electrical rhythm or result in a tamponade, whereby the sac around the heart fills with blood, thus squeezing the heart and impacting its ability to pump effectively. Other electrical problems can occur as well without precipitating trauma, such as heart blocks, atrial fibrillation, and other problematic conduction issues. Various disease pathologies can also impact the heart, such as valve prolapse or stenosis. If a person suffered a previous heart attack, the loss of associated cardiac muscle can have a profound effect on the heart's effectiveness as a pump. Prescribed medications can also contribute to shock by decreasing the heart rate or by interfering with the body's ability to elevate blood pressure when necessary. Adequate fluid commonly refers to blood, but can also include any body fluid. Dehydration due to inadequate water intake, burn injuries, vomiting, diarrhea, or excessive environmental temperatures can result in shock. Profuse bleeding is obviously a concern. Disease pathologies such as sickle cell anemia or carbon monoxide poisoning can also play a part in affecting the body's ability to adequately perfuse its cells, tissues, and organs. Vessel failure can occur through mechanisms other than trauma. Neurological dysfunction can result in dilation of vessels, thus increasing the relative size of our circulatory container. A severe allergic reaction can have the same effect, as can an infection. Extreme body temperatures, including hypo and hypothermia, can also impact the integrity of our vessels and their ability to function correctly. These are just some of the pathologies impacting our circulatory system that can result in shock. It is important to remember that patients do not always present with only a single pathology. Some patients will have multiple problems responsible for their state of hypoperfusion, some of which EMS providers simply cannot fix. That is why rapid assessment and identification of the signs and symptoms of shock is so important. In recognizing shock, the EMT should keep in mind the 3 different stages of shock. These stages progress from one to the next, sometimes slowly, other times very rapidly. There is no specific time frame associated with each stage, given that numerous factors play a part in the progression of hypoperfusion. Compensated shock is the first, early stage of hypoperfusion. In this stage, the body is experiencing some type of event, disease, or other stressor that is impacting the body's ability to perfuse its cells, tissues, and organs effectively. The body then makes changes to account for those problems. Some common compensatory mechanisms are increased heart and respiratory rates. The body wants more oxygen, so it tries to breathe faster and move the blood around the body quicker. Smaller vessels may be constricted to shunt blood and the oxygen it is carrying to more vital organs. At this point, the body is able to compensate for whatever problem is impacting its ability to perfuse. If the problem is minor or transient, the body may very well be able to compensate until things return to normal. If the problem is not that simple, however, the body may ultimately find itself unable to compensate fully for the issue or issues causing the hyperperfusion. Once the body begins to lose that proverbial battle, it enters a state called decompensated shock. In this stage, it is not uncommon for the patient to be pale with a low blood pressure despite an elevated heart rate. The body is running out of options and finds itself unable to adequately perfuse its cells, tissues, and organs. This is a later stage of shock in which immediate emergency intervention to correct the underlying pathology is required. Decompensated shock is a true emergency, and a failure to act quickly can result in the third state of hypoperfusion, irreversible shock. By its very name, irreversible shock is just that, irreversible. This is a terminal stage, and it is only a matter of time before death occurs. Delving deeper into these stages of shock, we will begin with a more thorough analysis of the first stage of hypoperfusion, compensated shock. Compensated shock occurs when the body detects some type of decrease in perfusion and the body's compensatory mechanisms are enacted. The sympathetic nervous system, responsible for the body's fight or flight response, releases epinephrine and norepinephrine within the body to elevate the heart rate and cause vasoconstriction, both of which help to maintain a perfusing blood pressure. The vasoconstriction works to shunt blood from the periphery into the core and vital organs, such as the heart, lungs, and brain. These chemicals also increase the respiratory rate in an effort to bring more oxygen into the body. By activating this fight or flight response with the sympathetic nervous system, the body is shifting itself into survival mode. When evaluating a patient who may be in compensated shock, some of the signs or symptoms that may be present include altered level of consciousness, anxiety, restlessness, combative, feeling of impending doom, increased pulse, elevated respirations, pale, cool, and clammy skin, thirst, nausea and vomiting, normal pupils, and normal blood pressure. The brain is very sensitive to oxygen deficiencies, which is why an altered level of consciousness may be expected of someone having difficulty adequately perfusing. Adding epinephrine and norepinephrine to a system that is already hypoxic can also increase anxiety, restlessness, and feelings of impending doom. Nausea and vomiting may occur because the body will attempt to shunt blood away from the gastrointestinal system in times of crisis. Pale, cool, and clammy skin is a result of that blood shunting as well. When the body is under stress, especially when it is trying to compensate for shock, the skin does not need much oxygen. At some point, if the body is not able to adequately compensate for the pathology causing its hypoperfusion, it will begin to tire and slip into decompensated shock. Stated another way, the body is losing its fight to maintain adequate perfusion to its cells, tissues, and organs. The signs and symptoms associated with a patient in decompensated shock are much more evident and dramatic. The individual's mental status starts to diminish further, and unresponsiveness is more likely due to increased hypoxia of the brain. The pulse remains fast, but it becomes weak and thready to the point where an EMT may have some problem feeling it, especially if palpating for a pulse in the periphery, such as a radial or popliteal pulse, given the body's attempt to shunt blood away from the periphery into the head and torso where the vital organs reside. Respirations remain rapid, but the quality changes as they become shallow and labored. The patient will feel weak as skeletal muscles receive less oxygen, and pallor or cyanosis, pale or blue-tinted skin, becomes evident, especially in areas of the body with thinner skin. Even in ethnic or racial groups with darker skin, the change in color is evident, especially in nail beds or around the lips and eyes. A decreased supply of oxygen to the eyes themselves will relax the iris, making the eyes dilated and sluggish to respond to light. Decompensated shock is also called progressive shock, and the body progressively loses its ability to compensate, and the person becomes increasingly ill. As the patient's condition progressively deteriorates, one of the last vital signs to be affected, especially in younger children, is the blood pressure. It is absolutely imperative that patients in decompensated shock receive aggressive emergency care and intervention. The earlier the patient receives that care, the higher the likelihood for a positive outcome. If an EMT waits for the patient's blood pressure to drop noticeably before taking affirmative action, given that the blood pressure is a later sign of decompensated shock, it may already be too late. Beyond decompensated shock is the last stage, irreversible shock. As denoted by the name, this stage of shock is irreversible. It is terminal. A patient in irreversible shock will soon be dead. Vital organs suffered for too long without enough oxygen. The kidneys, liver, and other organs are functioning anaerobically without oxygen, for the most part in an attempt to maintain the heart and brain, but the sacrifice is ultimately for naught. The cells of the body have been working without oxygen anaerobically, producing little ATP and lactic acid as a byproduct. The body's acid-base balance has begun to shift, and the cellular environment is becoming toxic as cells within vital tissues and organs begin to die. At a certain point, the body reaches and proceeds past a tipping point, and the negative effects of functioning without adequate oxygen can no longer be overcome, even with proficient and aggressive medical intervention. Signs and symptoms observable in this stage of shock include unresponsiveness, profound hypotension, significant bradycardia, eventually leading to pulselessness, and apnea. The pupils become fixed and dilated, and it is only a matter of time before all body functions fail and death occurs. As mentioned previously, the main causes of shock include fluid loss, pump failure, or cardiovascular system compromise. We'll look at each of these issues separately and discuss common patient presentations. Keep in mind that shock can result from any combination of these pathologies, whether it be just one, all three, or some combination thereof. Fluid loss precipitating hypoperfusion can occur multiple ways. If the body loses too much water or blood, it is said to be hypovolemic, suffering from a low volume of fluid, resulting in hypovolemic shock. Vomiting and diarrhea can result in hypovolemia, especially in the pediatric population. Because the skin helps the body retain internal fluids and moisture, burn injuries can have a significant negative impact on the body's ability to maintain fluid. More information on the pathophysiology of burn injuries and their treatment in the emergency care setting is provided in another module of this course. In those instances where hypoperfusion results from significant blood loss, the patient is said to be suffering from hemorrhagic shock. Stated another way, the patient is in shock due to hemorrhage. Treatment for these patients begins with careful monitoring of the airway, breathing, and circulation. Administer oxygen, maintain body temperature, control bleeding if present, and seek ALS intervention for fluid replacement therapy. If a traumatic injury is involved, consider cervical spine precautions if warranted. If a significant burn injury is involved, transport to a facility that specializes in burn treatment and care should be considered. The application of pneumatic anti-shock garments may also be necessary to help shunt blood out of the lower extremities into the torso and vital organs. If a person is experiencing hypoperfusion due to pump failure, he or she is said to be in cardiogenic shock. The patient is in shock because the heart is no longer pumping effectively to meet the metabolic needs of the body. There are numerous types of illnesses or injuries that can cause damage to the heart, resulting in cardiogenic shock. One such illness is congestive heart failure, CHF. This condition can be acute or chronic in nature. It is also commonly associated with another underlying pathology. CHF can result from a heart attack, a valve deficit, hypertension, high blood pressure, lung disease, pulmonary embolism, or a congenital heart defect, to name a few. An acute myocardial infarction, commonly known as a heart attack, results from an occlusion of a coronary artery with death to the area of the heart muscle that was formerly receiving blood and oxygen via the now occluded artery. Depending on where the blockage occurs and what area and how much of the heart is affected, the results can be mild to catastrophic. Heart attacks can be caused by atherosclerotic heart disease, prolonged coronary artery spasms, coronary embolisms, hypoxia, or a decreased cardiac output. Trauma or other injury can also damage the heart directly. A blow to the chest may disrupt the cardiac conduction system, resulting in arrhythmias. An impaled object into the heart can have a profound impact on its ability to function as well. Signs and symptoms of cardiogenic shock may include restlessness, anxiety, cool clammy skin, cyanosis, rapid weak pulse, rapid shallow breathing, shortness of breath, wet breath sounds, pale or ashen skin, decreasing blood pressure, possible chest pain, fatigue, diaphoresis, feeling of impending doom, denial, altered level of consciousness, nausea, and vomiting. Management of a patient in cardiogenic shock will differ from patient to patient. If the patient appears to be suffering from an acute myocardial infarction, administration of aspirin along with patient-assisted nitroglycerin may be warranted by local protocols. If a patient is pulseless, CPR should be performed and an AED applied for potential defibrillation. Regardless of the pathology underlying the cardiogenic shock, monitoring ABCs is of paramount importance. These patients are already having problems perfusing, so supplemental oxygen administration is also warranted. Rapid transport is important, and, if available to the service, advanced life support should be utilized. A number of pathologies can cause the container or network of blood vessels in the cardiovascular system to fail. Each situation is unique with different signs, symptoms, and respective interventions. Hypoperfusion due to container failure may be classified as anaphylactic, neurogenic, septic, psychogenic, or metabolic shock depending on the underlying pathology. Anaphylactic shock occurs when the immune system overreacts to some type of antigen, such as an insect bite or sting, medications, certain foods, or chemicals, including soaps, colognes, and perfumes. Signs and symptoms commonly include difficulty breathing, stridor, wheezing, and hoarseness, given swelling of the airways. Hives, also called urticaria, are common but not always visible. Hives may be present with wheals, which are itchy patches of elevated skin. Swelling may occur, and hypotension is a common sign due to widespread vasodilation. Due to possible airway compromise as a result of swelling, monitoring the status of the patient's airway, breathing, and circulation is essential if anaphylactic shock is suspected. Administering high-flow oxygen and maintaining body temperature will also aid in managing this patient. Administration of epinephrine and albuterol are common treatments if permitted by local protocol. Rapid transport is important. If available, advanced life support should also be utilized. Injury to the spinal cord can result in a loss of sympathetic vascular tone, which leads to massive vasodilation. Injuries to the brain, neurological tumors, or conditions like spina bifida can also result in perfusion problems. In cases where hypoperfusion results from a problem with the neurological system, the patient is said to be suffering from neurogenic or spinal shock. Signs and symptoms of neurogenic shock differ slightly from other types of shock because the body's normal compensatory messages are disrupted while traveling through the neurological system. Nerve impulses fail to reach the muscles within blood vessels, resulting in a relaxation of those muscles, systemic vasodilation beyond the area of nervous system compromise, and a drop in blood pressure. The mechanics of breathing may be impaired given a brain or spinal cord injury with a presentation that may include diaphragmatic breathing. Thermoregulatory mechanisms within the body may also be affected, with skin below the injury site remaining pink, warm, and dry, while the area above the injury site is pale, cool, and diaphoretic. Numbness or paralysis in extremities may or may not be present. Male patients with a spinal cord injury may also present with a priapism, a prolonged, unwanted, persistent, painful erection unrelated to sexual stimulation or arousal. As with other kinds of shock, monitoring the patient's airway, breathing, and circulation is of primary importance. Be prepared to support respiratory efforts with assisted ventilations and high-flow oxygen administration. Depending on the mechanism of injury, it may be necessary to take C-spine precautions. Additionally, help the patient maintain his or her body temperature, transport rapidly, and consider calling for ALS assistance if available. To help put the next type of shock into context, think of a septic system. A septic system is essentially a private sewage system for an individual household, meaning the system is full of waste, decay, bacteria, and other unhealthy organisms and toxins. Someone suffering from septic shock or sepsis has somewhat of the same thing happening within his or her body. Essentially, there is widespread infection within the body. The environment within the body is no longer healthy for the organism. It is toxic, septic for the person. Sepsis is a very complex pathology. The part that impacts perfusion resulting in shock is that the infection results in a loss of vascular tone. As the vessels dilate, the container grows in size and the patient essentially enters a state of relative hypovolemia. What is normally an adequate volume of circulating blood is no longer adequate to fill this large cardiovascular system given the dilation of all the vessels within it. In addition to the loss of vessel tone, the sepsis also impacts the ability of the cells to utilize oxygen and glucose effectively. As the person is already septic, it should be apparent that the body is already struggling with its immune response and may not be able to successfully combat the infection without aggressive medical intervention. Septic shock may result from a serious illness, multisystem trauma, or from an exposure to a virus, bacteria, or other communicable disease agent. Unfortunately, many septic patients contract their illness while in hospitals during or after invasive procedures. Some common signs and symptoms for a patient in septic shock include an altered level of consciousness, increased pulse and respiratory rates, low blood pressure, and signs and symptoms associated with the infection itself, such as fever, chills, and sweating. Patients in septic shock need definitive, aggressive, managed health care. In the field, it is important to monitor and maintain the patient's airway, breathing, and circulation. High flow oxygen should be administered, and ALS should be utilized if available. Rapid transport is essential because these patients really do need care at a hospital. Depending on the nature and seriousness of the sepsis, however, even that may not be enough to turn the tide of the infection. Commonly observed in diabetic and dialysis patients, metabolic shock can result when a patient has an imbalance between the production and elimination of acids within the body. A significant fluid imbalance can also result in metabolic shock as well. Patients in metabolic shock may present with an altered level of consciousness, increased pulse, rapid respirations, snoring, dizziness, or weakness. Patient care should include monitoring the patient's airway, breathing, and circulatory status, administration of high-flow oxygen, measurement of blood glucose, maintenance of body temperature, and expedited transport with consideration for an ALS intercept. One type of shock we will discuss here that is no longer defined as shock in many textbooks is psychogenic shock. Psychogenic shock is now commonly called psychogenic, non-cardiac, or vasovagal syncope. In layperson's terms, this type of shock results in fainting. It is temporary in nature and is usually precipitated by anxiety, fear, excitement, or other extreme emotional responses. In these instances, a person experiences a strong emotion, triggering the body's fight or flight response. The activation of the sympathetic nervous system then triggers a subsequent reflex vagal reaction. The rapid constricting and dilating of blood vessels can create a temporary relative hypovolemia, reducing blood flow and subsequent oxygenation to the brain. Signs and symptoms associated with this type of shock may include a sudden loss of consciousness, fainting, or something less drastic such as dizziness, anxiety, loss of vision, or loss of hearing. Pallor, diaphoresis, thready pulse, and low blood pressure may also be present. Some common causes of psychogenic syncope include grief, fear, joy, anxiety, or any other overwhelming emotional response. With that being said, it is also important for the EMT to perform a differential diagnosis to ensure the syncopal episode is not the result of another underlying pathology, such as dehydration, medication imbalance, orthostatic hypotension, hypoglycemia, or a cardiac dysrhythmia. If the syncope was truly a psychogenic event, it should be short-lived and self-correcting. Regardless, it is still important to monitor and maintain the patient's airway, breathing, and circulation. Oxygen administration may help the patient's recovery. Be mindful of the patient's position, as standing or sitting up may prolong the episode. If a ground level fall occurs following a fainting spell, be certain to properly manage any resultant injuries, which may include spinal precautions. It will be imperative to evaluate for underlying causes, which will mean checking a blood sugar level, among other things. The proper management of a patient in shock begins with a thorough patient assessment. As covered elsewhere in this course, the EMT must perform a scene size-up, conduct a primary assessment, obtain relevant history, perform a secondary assessment, and be sure to reassess the patient as necessary. By now, given our analysis of different types of shock, you should have a good idea of how to treat a person suffering from hypoperfusion. In general, be mindful of the mechanism of injury and be certain to take spinal immobilization precautions if necessary. Monitor and maintain the patient's airway, breathing, and circulation. This may mean suctioning the airway, controlling external bleeding, or performing CPR. As the person is having difficulty perfusing oxygen to his or her cells, the administration of supplemental, high-concentration oxygen is warranted. Position the patient appropriately for transport and help the patient maintain his or her body temperature through the use of blankets and forced air heat in the back of the ambulance. If supported by your scope of practice and protocol, administer medications as necessary and be certain to expedite transport while also considering the need to utilize advanced life support services if available. Definitive care at a hospital will increase the patient's chances for a positive outcome, so be mindful of time spent on scene performing your assessment and any interventions. If the secondary assessment and other interventions can be performed en route to the hospital, then do so rather than using valuable time at the scene. Shock is shock, regardless of the age of the patient. Whether the patient is 8 months old or 80 years old, shock still remains the inability to adequately perfuse the cells, tissues, and organs of the body. While this definition is the same across age groups, there are special considerations to keep in mind when shock strikes the very young or the very old. Shock commonly occurs in pediatric patients due to trauma, fluid loss, or infection. When trauma is involved, blood loss must be a concern for the EMT, as the younger the child, the less circulating volume of blood, and the more profound the effect of blood loss. Abdominal injuries can result in significant internal bleeding, and chest wall injuries can have a significant negative impact on the pediatric respiratory and cardiovascular systems. Diarrhea and vomiting can be commonplace for infants and younger children, leading to fluid loss that can result in perfusion issues. Dehydration in general can also have the same result. Allergic reactions, poisoning, and cardiac issues, such as congenital heart disease, are usually less common causes of shock in the pediatric population. Signs and symptoms of shock in the pediatric patient may be more or less pronounced, depending on the specific sign or symptom. Weak or absent peripheral pulses and delayed capillary refill time, greater than 2 seconds, are consistent with adults. As seen in adults, increased respiratory rates are common as the body tries to increase oxygen intake while also combating acidosis, given decreased tissue perfusion by exhaling carbon dioxide in greater quantities. Pale, cool, clammy, or mottled skin may be present given decreased circulation to the capillaries in the skin. As the body loses its ability to adequately perfuse the brain, mental status changes are common. In instances where fluid loss is an issue, the child will have decreased urine output. In younger children, this means dry diapers or fewer wet diapers. The absence of tears when crying may also be a sign associated with dehydration. Dehydrated infants may have sunken fontanelles, and tenting of the skin may be noted as well. A tremendous difference in the pathophysiology between children and adults is the ability of children to compensate for hypoperfusion by maintaining an adequate blood pressure right up to the time of a dramatic and often fatal crash in that blood pressure. Some resources state that an infant can maintain a normal blood pressure even with a loss of up to 1/2 of his or her normal circulating blood volume. Thus, by the time an EMT notices a decrease in the child's blood pressure, it may be too late to do anything about it. The EMT must use critical thinking along with a thorough assessment to recognize other signs and symptoms of pediatric shock. Rapid identification of shock, aggressive treatment, and rapid transport are very important for the continued health of a pediatric patient experiencing hypoperfusion. As with the adult patient, transport should not be delayed for the pediatric shock patient to complete assessments and interventions. It is important to begin transport as quickly as possible for pediatric patients in shock, performing assessments and interventions en route. Be sure to consider the mechanism of injury, paying special attention to the need for spinal immobilization. Persistently monitor the patient's airway, breathing, and circulatory states, as it can change rapidly with little to no warning in the pediatric patient. Suction any secretions as necessary and be ready to ventilate if indicated. Control any external bleeding. Provide high-flow oxygen and consider elevating the patient's legs during transport if not contraindicated by head or spinal cord injury. Pediatric patients, especially newborns and infants, lose a lot of body heat through their proportionately larger heads. Keep the patient warm and help them maintain their body temperature. If the patient is in anaphylactic shock, consider the administration of epinephrine. If the patient has a low blood sugar, consider the administration of glucagon. Along those lines, advanced life support is of tremendous benefit to the patient with hypoperfusion. The ability to initiate IV therapy, along with the administration of additional medications, makes ALS intervention the gold standard for pre-hospital care and treatment of a patient in shock. As a person ages, subtle changes occur related to the anatomy and pathophysiology of various body systems. As far as shock is concerned, the causes, signs, symptoms, and patient care considerations do not vary much given an older population. With that being said, geriatric patients do not compensate as well for hypoperfusion and tend to have health and other complications not commonly seen in the younger population. The effects of prescribed medications and the deterioration of organs and body systems are factors an EMT must consider when assessing and treating a geriatric patient for shock. More information as it pertains to the assessment and treatment of geriatric patients with shock can be found in the Special Populations module of this course. That concludes this module on shock. You should now be able to define shock hypoperfusion, discuss components for normal perfusion, list the causes of shock, list the 3 stages or categories of shock, and differentiate between signs and symptoms of the 3 stages. Identify the compensatory mechanisms related to shock. List various types of shock. Differentiate between causes, signs, and symptoms of the various types of shock. Explain appropriate care for patients exhibiting signs and symptoms associated with each type of shock. Discuss general assessment components of adult and pediatric patients. Analyze the need for expedient care and transport of shock patients. And describe age-related variations when assessing and treating a pediatric or geriatric patient in shock. You should also be able to explain the sense of urgency to transport patients that are bleeding and show signs of shock. Explain the rationale for having knowledge and skills appropriate for dealing with pediatric and geriatric patients in shock. Problem solve how to appropriately provide emergency care for a patient exhibiting signs and symptoms of shock. This presentation was created by Waukesha County Technical College with grant funding from the Wisconsin Technical College System.